I think we should start. Good morning and welcome back to the APLC second session on CLL. So for this session, the first talk will be given by Professor Paolo Ghia. Professor Ghia is a professor of medical oncology at the University San Raffaele, Milan in Italy. And he is also the director of the strategic research program on CLL in the same center. Of course, his research interest is in CLL, and he has published widely and is an active researcher in the field of CLL. He is currently the president of the European Research Initiative on CLL-ERIC, and also member of the International Workshop of CLL, IWCLL, and also an associate editor of Hemisphere, the official journal of EHA. Unfortunately, Professor Ghia is unable to join us in person, but he will be deliver his talk via online means. So, Paolo, please.
Yes, hello to everyone. Good morning to you. And yes, indeed, unfortunately, I cannot be there with you. I would have loved to be, but I hope I will do a good presentation anyhow virtually. So as you see here, the title is Practice Changing Updates in 2023, and I will try to summarize what has been shown to be relevant also for clinical purposes in the last 12 months, so starting last ASH meeting. And so these are all my disclosures, and we start from the evidence that we presented indeed 1 year ago of the efficacy of BTK inhibitors in CLL, and that has translated in the possibility for our patients now, if they are treated with continuous BTK inhibitors, in particular in this case ibrutinib, to achieve a life expectancy that is exactly identical to that of healthy individuals. And that has been obtained thanks to, as I mentioned, to ibrutinib, to a BTK inhibitor that has become now in the last 10 years one of the two major pillars of the treatment in CLL. The other pillar being the BCL2 inhibitors, and I will be talking about that. The BTK inhibitor has been so successful that now we have more than a single molecule. We have actually 3 generations of molecules, and I will be talking about ibrutinib, but also the second generation BTK inhibitors, acalabrutinib and zanubrutinib. Pirtobrutinib and emtabrutinib are considered third generation BTK inhibitors, non-covalent BTK inhibitors, and they are still to be approved, but they look to be promising in patients relapsing and becoming refractory to first and second generation inhibitors. Having said that, we know, and I just do a quickly overview of things that probably you all know, that ibrutinib and so the continuous BTK inhibition has shown to be more effective in terms of progression-free survival, also overall survival, in this case, compared to fludarabine, cyclophosphamide, and rituximab. So in the context of young, fit patients. Here, both mutated and unmutated appear to have equal benefit compared to FCR, and this is the ECOG 1912 study presented, published 1 year ago by Tai Shanafed and the other US colleagues. Jennifer Voyak presented and published also another study showing how continuous BTK inhibition is better than chemoimmunotherapy, and in this case is ibrutinib was compared to bendamustine plus rituximab. So we are in the context of elderly but still fit patients who can tolerate potentially bendamustine plus rituximab. The study here was a comparison of ibrutinib alone or in combination with rituximab, and it showed again an overwhelming better efficacy compared to bendamustine plus rituximab. Last but not least, the RESONATE-2 study, where ibrutinib was compared to chlorambucil. So we are in the setting of elderly patients, unfit patients, patients with comorbidities who 10 years ago were deemed to be treated with the chlorambucil-based treatment. And the impressive result of this study is that after more than 7 years of follow-up, we did not yet reach a median progression-free survival. So 59% of the patients are still responding after 7.4 years of follow-up. And there is also, as I didn't show you in the previous studies, but with ibrutinib, we've been also able to eliminate the difference between unmutated and mutated patients. So patients with unmutated immunoglobulin genes who usually tend to respond much less to, for example, immunochemotherapy, they tend to progress earlier. Instead, with continuous BTK inhibition, they obtain the same progression-free survival. This impressive result has been also obtained in the category of the so-called high-risk patients, so those who have p53 aberrations, either p53 mutations or deletion 17p, where we are losing the short arm of chromosome 17, where the p53 gene is located. And as you can see from this pooled analysis of different studies where all the patients with p53 aberration have been pooled together, then you do see that the progression-free survival appears to be, again, very impressive, even in this high-risk category of patients, with a 4-year progression-free survival that is in the range of 80%. So 4 out of 5 patients still responding after 4 years. And in the study on the right side, a phase 2 study run by Adrian Wisner at NIH, we have a progression-free survival at 6 years of 61%. So almost 2/3 of the patients who are still responding, even if they were carrying p53. Of course, we also learn by using BTK inhibitors, in particular ibrutinib, is that there is a new set of adverse events. In particular, I focus my attention on the right side. So we learned that ibrutinib was associated with a cardiovascular toxicity, in particular hypertension, that tend to increase with time, so with the prolongation of treatment. Atrial fibrillation that is somehow constant throughout the treatment, and also bleeding risk. And in particular, what we have to inform the patient is the risk of major bleeding, so intracranial or gastrointestinal, that fortunately are rare, around probably 1%, but still patients should be informed so that they can seek help in case of symptoms. So for this reason, a second generation of BTK inhibitor have been developed. I mean, the efficacy was overwhelming, and definitely it's a class of drug that should be used and exploited. But of course, the adverse events are somehow of concern for the physician. So the two molecules, acalabrutinib in particular, which is, if you look at the kinase selectivity compared to ibrutinib on the left, is very much more specific. And then also zanubrutinib that tend to be somehow in between the two molecules in terms of selectivity. And this with the idea of having a better toxicity profile so that some adverse events could be avoided. So the acalabrutinib plus or minus obinutuzumab, so the anti-CD20 antibody, has been compared to chlorambucil plus obinutuzumab in the ELEVATE treatment-naive study. So having as comparator chlorambucil plus obinutuzumab, you understand that the setting here is again elderly patient with comorbidities. And what has been presented CHA last year is the 5-year follow-up, where now we have a long follow-up even also with this more novel molecule. And as you can see, compared to chlorambucil plus obinutuzumab, it has a much better progression-free survival. And in particular, what is interesting is that in the black line, where acalabrutinib is associated to obinutuzumab, we have even a more prolonged progression-free survival. So we have an advantage when adding a monoclonal antibody. And this very impressive progression-free survival, roughly 70% in 5 years, we do see that also in patients with 17p and p53 aberration. So again, reminding us that with the continuous BTK inhibition, we can really keep control of patient with p53 aberration. And on the right side, we do see again that we eliminate the differences between mutated and unmutated patients. In terms of toxicity, from using acalabrutinib, so second generation BTK inhibitor, we do see that there is apparently an improvement in terms of adverse events, because here we are looking at the treatment emergent adverse events, so those that appeared in the 5 years of follow-up. And as you can see here, hypertension is roughly 10%, so divided by 5 years is roughly 2% per year. So probably very likely to be similar to the background level, to what would happen in an elderly population. Bleeding remains high, but interestingly enough, also atrial fibrillation 6.2, and divided again by 5 years is 1.5 per year. So it's something very similar to what we would expect in an elderly population. So we move then to the other second generation BTK inhibitor, zanubrutinib, that has been tested in the Sequoia study. And the Sequoia study is a complicated study, but we look only at the cohort 1, where elderly patients, but still fit patients, have been randomized to zanubrutinib continuous therapy or bendamustine plus rituximab, so similar to the study that ibrutinib, the alliance study with ibrutinib. And in this case, since the patients were exposed potentially to bendamustine plus rituximab, the patient with deletion 17p have been enrolled in a separate cohort that was treated only with continuous zanubrutinib. And these are the results. The follow-up is much shorter now. We have a little bit longer than 2 years, and at ASH we will be presenting a much longer follow-up, so be ready for that. But the data is absolutely in line with what we have seen with Acala and ibrutinib, so very sustained progression-free survival, definitely better than the bendamustine plus rituximab. On the right side, again, mutated and unmutated patients behave similarly. And in the left bottom corner, you can see the patient with the deletion 17p that have been treated only with zanubrutinib. And again, you can see that almost 90% are still responding after 2 years of treatment. In terms of adverse events, again, we do see some improvement, but that in particular, we have to think now that we are looking at 2 years, a little bit more than 2 years of treatment. We can see that hypertension remained quite high, 14%, so it's 7% per year. Atrial fibrillation is 3%, so again, probably 1.5% per year if we consider 2 years of follow-up. And therefore, again, it looks like with the second generation BTK inhibitor, we can have much lower atrial fibrillation. In particular, probably these are the level, the frequency, the incidence that you would expect among the elderly patients. But interestingly, both molecules have been, both acalabrutinib and zanubrutinib have been compared directly to ibrutinib. The only problem is that they have been compared in the relapsed refractory setting, not in frontline, but still the information can be useful. The Elevate RR, so relapsed refractory, randomized relapsed refractory patient between acalabrutinib and ibrutinib. In this case, the patients were high-risk patients, so patients with deletion 17p and or deletion 11q. So the primary endpoint was non-inferiority, and the second endpoint are much more relevant for us in this situation because they were incidence of atrial fibrillation, incidence of infection. So we are talking about safety of the molecule. And as you can see here, the primary endpoint has been met. There is no difference in terms of efficacy in progression-free survival between ibrutinib and acalabrutinib. And but an interesting point is, of course, the safety profile. And here we can really compare the two molecules. And as we already alluded in the Elevate TN study in frontline, you do see here that there is less atrial fibrillation, there is less hypertension, and there is also less bleeding events, though, of course, still 1/3 of the patients may have bleeding events, but 50% would have with the use of ibrutinib. And what is interesting to note is from the curves on the right side for atrial fibrillation and hypertension, that the curves with acalabrutinib are flatter compared to ibrutinib, somehow suggesting that the administration of ibrutinib really has an acute effect on the heart function. That so there is a peak of atrial fibrillation and hypertension that is in the first 6-12 months, and then again the curve will level off. When we move to zanubrutinib was compared in the Alpine study, zanubrutinib versus ibrutinib in all relapsed refractory patients with CLL. And in this case, the primary endpoint was superiority in terms of overall response, and secondary endpoints again was safety and PFS. And the study showed indeed that zanubrutinib achieved much more frequently a response compared to ibrutinib, 86% compared to 75%. And also what they showed is that there is an advantage in terms of progression-free survival for all patients, and also for those with deletion 17p and p53 status, though the number, the PFS shown by ibrutinib in this particular study seems to be the lowest that have been achieved in all the different clinical trials. In terms of adverse events, again, the direct comparison between ibrutinib and zanubrutinib somehow confirmed what we already seen in the study, the original study of zanubrutinib with the multiplus. So we have a significant difference in terms of atrial fibrillation, much less with zanubrutinib compared to ibrutinib, but hypertension is absolutely identical, exactly as bleeding. So probably, as I alluded earlier, from the selectivity of the molecule, again, the zanubrutinib seems to give an advantage in terms of atrial fibrillation, but not in terms of hemorrhage and hypertension. In the last EHA, last June, 3-4 months ago, we presented data comparing acalabrutinib versus zanubrutinib. Of course, this was done from a statistical point of view in a so-called match-adjusted indirect comparison, because we were not really convinced that second generation might be better in terms of efficacy compared to ibrutinib, given the fact that the mechanism remains exactly the same, and so the inhibition of BTK. And indeed, from our indirect comparison, that of course is not a clinical trial, so one has to be cautious in the interpretation. But even after matching the two population of the studies, so by selecting those who much more resemble each other, then you can see that the PFS of Acala and Zanu are very much superimposable. While instead, in terms of safety, you confirm what I mentioned earlier. So both of them are have a very similar frequency of atrial fibrillation, but acalabrutinib has an advantage in terms of minor bleeding and hypertension. Having said that, we have been talking about continuous treatment that is definitely very effective, but of course we are somehow attracted by fixed duration treatment because we can stop the treatment, we can save resources, but in particular we can probably also prevent adverse events with without a long exposure to the drugs and also the other point that they didn't touch so far, we can probably also avoid the occurrence of resistance to the drug. So one of the possibility to stop treatment is given by venetoclax-based treatment, because venetoclax achieves BCL2 inhibitors achieve very deep responses, in particular undetectable MRD. And Osman Al-Sawaf from the German CLL study group presented at EHA this year the 6-year follow-up of the CLL14 study, where venetoclax plus obinutuzumab given for 1 year, 1 year of venetoclax in the first 6 months of obinutuzumab was compared to chlorambucil plus obinutuzumab. So again, we are talking about elderly, frail patients. And the 6-year follow-up is very reassuring, meaning that the overall survival has not been yet reached, even after 6 years of follow-up. 53% of the patients are still responding. But when we look at subgroups from a genetic point of view, I mentioned earlier that with continuous BTK inhibition, we don't see any more differences between mutated and unmutated patients, or with the patient carrying P53 aberrations. Here, instead, the situation seems a little bit different. So with the fixed duration of 1 year, this particular fixed duration, patients with P53 aberration tend to progress much earlier, and indeed they have reached a median progression-free survival at 51 months. So 4 years, and half of them progress, 1 year of treatment, 3 years of therapy. So it's probably a little bit too short from what we expect than what we would expect with the continuous BTK inhibition. When we look at patients stratified by immunoglobulin gene status, then we do see that patients with unmutated immunoglobulin genes, they tend also to progress earlier. And also here, a median progression-free survival has been reached, 65 months, so more than 5 years, which is better than P53, but still it could be probably a little bit shorter than what we obtain with BTK inhibitors, though we don't have a direct comparison between these drugs, and we will be seeing the results of the CLL17 study that is comparing ibrutinib versus venetoclax plus obinutuzumab versus ibrutinib plus venetoclax. Of course, with the fixed duration, after we stop the treatment, we don't see any more adverse events. So this is something that we all expected, we wanted to see with the fixed duration, and in fact, that can be obtained. With venetoclax plus obinutuzumab, it remains to be clarified if there is or not an increase in second primary malignancies. There is an increase in numerical terms of a second primary malignancy with venetoclax plus obinutuzumab, though it is not yet statistically significant. So the investigators, the German colleagues, are keeping an eye on this to see if and how the effect of these two drugs may last for much longer, given this risk of second primary malignancy. What we also learned from Osman Sawaf a few months ago is that we are not achieving cure with venetoclax plus obinutuzumab. That's not the objective. The objective is only to limit the amount of drug that we give to patients. And indeed, you can see that undetectable MRD is decreasing by 5 years. Virtually very few patients, if none, are still in the undetectable MRD status. What we have also seen is that, but we already knew that from chemoimmunotherapy, is that when you consider a patient who did not reach undetectable MRD, those are the patients that are progressing much earlier. And the median progression-free survival of this patient is very short. So making this particular population the unmet clinical need for these patients, definitely the fixed duration treatment is not the best option. Unfortunately, we can discover them only after giving the drug. But more importantly, these patients are also dying earlier. So this is definitely a much more difficult category of patients to be treated, so that we cannot even rescue later on with BTK inhibitors or other therapies. So this is something that we have to keep in mind, and probably this has to become the focus for research in the near future. Another possibility of fixed duration is given by the combination of a BTK inhibitor and a BCL2 inhibitor. And the first study that had been performed and that we designed together with Bill Virda and Konstantin Tam is the Captivate study, where patients were treated with 3 months of ibrutinib to debulk the patient, and then 12 cycles of the combination ibrutinib plus venetoclax. One cohort of patients was treated based on MRD, but I will be talking today, we'll be showing you the results of the fixed duration treatment. So all patients at the end of the 12 cycles of combination stop the treatment. And we presented the update at ICML at the Lugano meeting in June 2023. And we show that the responses of the patients remain quite stable. So you can see that there is a drop in the first year, but then between the second and third year, the responses remain quite stable. And also the loss of undetected MRD seems to be much slower than what we have seen with the venetoclax plus obinutuzumab. But this translates also in very reassuring progression-free survival, where you see that at 4 years, all patients, virtually 80% of all patients still remains responding, and also patient that applies also to patients with unmutated hemoglobin gene, where there is not a significant difference between the two. The only exceptions are the patient with deletion 17p and or p50 mutation, who tend to progress a little bit earlier. So again, probably the fixed duration treatment is not yet the best therapy for these patients. Interestingly, if you look at patients who did not achieve undetected MRD, you can see that the progression of the patient, though worse than those who reach undetected MRD, but still it's much more, it's much slower compared to what we have seen with venetoclax plus obinutuzumab. And this can, just to, all physicians are concerned of using the combination up front because they have the feeling of using all their possibility of drugs, while this is not true because the patient who progress, they can be retreated with the combination, and we will be seeing the results at the next ASH. We will be presenting that, or with a single ibrutinib, single BTK inhibitor, as I presented here at the Lugano meeting, where all patients who progressed and needed treatment have been treated with ibrutinib, and all of them obtain a response, most cases partial responses, as we would expect with BTK inhibitors. In one case, progressive disease, but this was a Richter transformation that was diagnosed after 1 month after starting a treatment, or a stable disease that became a partial response with a longer follow-up. So patients are responding if they progress after the combination, they can still respond to the drugs because indeed they did not become resistant during 1 year only of treatment. And in terms of safety, the adverse events that we have shown are very similar to what you would expect with single therapy, with the exception of diarrhea that appears to be accumulate with the two drugs, but most of them, if not all of them, are grade 1 and 2. Interestingly, you have neutropenia due to venetoclax in grade 3 and 4 in 1/3 of the patients, but that does not translate into higher infection. This is the Captivate study, so mainly young patients. In another study, GLOW, that enrolled elderly patients, we do see the similar numbers of neutropenia, but much higher infection. So we have always to keep in mind that, in particular, when we think about combination, we have to think also the possibility of more toxicity, in particular in the elderly population. And with this, I conclude, and I just remind you that indeed to choose nowadays, having so many possibilities, we have to choose the treatment for our patients. We have to still understand and know the genetic of the disease, because we can choose between continuous treatment and fixed duration treatment. We have to know the patient, the comorbidities, cardiovascular toxicity. We have to know the drugs and the difference between the drugs so we can choose the best. And of course, we have to also to keep into consideration the patient perspective. With that, I conclude, and I thank all my collaborators in Milano and around the world. Thank you very much for your attention.
So thank you, Paolo, for the very nice, comprehensive overview on the treatment of CLL in the modern era with all the novel agents, be it continuous BTK inhibition or fixed duration BCL2 inhibitor with venetoclax. So now the session is now open for discussion, question and answer. So anyone have any questions? Yes, Lalita.
Hi. Okay. Hi. I'm Dr. Lalita from Chiang Mai University. So I'm gonna start with the first questions. For patients with 17p deletions or TP53 mutations, which one would you prefer for the treatments between BTK or venetoclax, or you would prefer the combinations treatment?
Oh, that's indeed a very nice question. At the moment, and I think also the guidelines, we saw the German guidelines, and we will have also soon the ESMO guidelines that will be updated. They still recommend for the patient with P53 aberration, they recommend continuous BTK inhibition. Venetoclax-based treatment seems to give a little bit less to these patients. And in particular, we have also shown that with ibrutinib plus venetoclax, we achieve undetectable MRD in a much lower frequency in patients with P53 aberration. It would be interesting to see what happens in patients who achieve undetectable MRD, because the numbers are too low in our study, so we don't really know. It might be that one strategy in the future will be to apply a BTK inhibitor plus BCL2 inhibitors and then check for MRD and stop only those who achieve undetectable MRD. But this, of course, off-label is MRD is not yet incorporated in our decision. So at the moment, continuous BTK inhibitors, I think, remain the best therapy for patients with P53 aberration.
Yes, Professor Go.
Thanks, Paolo, for a very comprehensive talk. We know that the choice has always been between fixed duration and continuous therapy, and we know that most patients and even physicians will prefer a fixed duration therapy. But of course, with the VAN-O, we have the shortcomings of the CL14 with the poorer intermediate and the bad risk groups. With the data that you've shown for I+V from Captivate and the 4-year update for GLOW at EHA this year, showing very good data for especially the IGVHV high-risk group. Would you say that that's a nail in the coffin for VAN plus O? And would you then say that would there be still any group that you would choose VAN plus O given the data?
Yes, indeed. No, thank you for the question. I think, as I mentioned, the genetic features of the disease remain very important to make decisions. And in fact, I use it personally. So VAN-O is definitely the choice for patients with mutated immunoglobulin genes. The responses are very nice, very stable. We don't know yet if it is as stable as with FCR in the fludarabine cyclophosphamide and rituximab, but still this treatment can be applied to any patient, including also the elderly patient. For unmutated patients, I think that the choice is really probably we have to listen to patient preferences, because probably the BTK inhibition remain the most effective treatment. I would, in particular for young patients, I would suggest to use a combination of BTK inhibitors and BCL2 inhibitors so that they can enjoy a fixed duration treatment with a very prolonged progression-free survival. And of course, also the possibility to be retreated with the same drug.
Thank you, Paolo. Now we have quite a few questions submitted. Now, the first question is for high-risk CLL, I think, which was published in the New England Journal of Medicine by the MD Anderson Group, using I plus V for 2 years instead of 1 year. Apparently, it might actually increase the percentage of undetectable MRD for 2 years treatment. So what do you think about this approach, prolonging the fixed sort of duration from 1 year to 2 years?
Yeah, nobody knows what the truth is. I have to say that in the data from Houston, from Bill Virda and the colleagues, looks a little bit strange for the simple reason that it's true that they obtain more undetectable MRD with 2 years compared to 1 year. But at the end of the day, they achieve like 75% of undetectable MRD in the bone marrow that we have shown in the Captivate study to be achieved after 1 year in our study. The drugs are the same, so it's difficult to understand why we have such a difference. It is true that by adding an extra year, you do get better responses, and we have shown that also in the Captivate in the MRD cohort. So patients who did not achieve undetectable MRD after 1 year were randomized to either ibrutinib alone or I plus V, and indeed the number of cases who achieved undetectable MRD improved with the second year. And Pete Hillman will show at ASH this year the update of the FLAIR study, where they treated patients with I plus V, ibrutinib plus venetoclax, and the length of treatment was dependent on the time they needed to achieve undetectable MRD. So if they needed 1 year, they were treated for an extra year. If they needed 2 years, they were treated for an extra 2 years, and so on and so forth. So the general idea is that the more you give, the better it is in order to achieve undetectable MRD. But we have also to understand that we might increase the toxicity, and we have also to know what is our objective. If we want to achieve cure, so maybe we have really to add therapy, or if we want just to give a drug holiday to the patient, thinking about treating and then stopping, retreating, and then stopping and retreating. So it really, again, depends probably on the age of the patient, on the preferences of the patient.
I see, thank you. So the next question is anti-CD20 therapy still have a role in CLL? I suppose it's in combination with BTK inhibitor for continuous treatment. Yeah. Do you think that is still having a role for anti-CD20 antibody?
In particular, the data with acalabrutinib appears very promising. There is an advantage in terms of PFS, and again, an advantage that probably might benefit more the young patients rather than the elderly. The issue is that you would still need to continue the therapy. So it would be nice to do a study with the combination of anti-CD20 and try to stop also the BTK inhibitors.
So just to follow up on that question, so do you mean that it's only for acalabrutinib that you may consider adding on, say, obinutuzumab, but not, let's say, for ibrutinib?
Yes, with ibrutinib, we didn't have any evidence that the addition of anti-CD20 has an impact. Definitely rituximab in the Alliance study was compared head-to-head ibrutinib or ibrutinib plus rituximab, and it didn't show any difference in terms of PFS. We have a study, Illuminate, where ibrutinib was associated with obinutuzumab. There was not a direct comparison with ibrutinib alone, but the PFS that was shown in that study was not very different from what we have seen with ibrutinib alone in other studies. So there is no evidence that anti-CD20 are beneficial with ibrutinib, and in general, nobody recommends to use it. While instead with Acala, it could make a difference.
Right. So one more question is, in clinical practice, can fixed duration treatment like ibrutinib venetoclax or acalabrutinib venetoclax or sanibrutinib venetoclax consider in TP53 mutated or deletion 17p patients? Or do you suggest continuous BTK treatment?
We need data, we need a study. I have the feeling and the hope that we could use it also in patients with P53. The combination can be used also in patients with P53 aberrations, provided that they reach undetectable MRD. That would make me much more confident. It would be nice to have data from a clinical study. And probably again, one should not do a fixed duration treatment, but probably a time-limited MRD-driven treatment, so that you decide when to stop based on the MRD. But this is more a design of the study rather than a suggestion for clinical practice.
Perhaps we have one last question submitted. So please share your view on resistance and mutation associated with first generation and also second generation BTK inhibitors. What should be the treatment strategy for patients who progressed with BTK inhibitors?
Yes, that's a very interesting question. It's a topic for research. At the moment, we do not need to check for mutations, and we don't have to take any decisions on the presence or the absence of mutations. The mutations in BTK can occur with all inhibitors, first, second, and also third generation. They can be slightly different depending on the inhibitor. It might prevent the effect of one inhibitor or the other inhibitor. That is not yet proven at clinical level, only in vitro. We don't know how much mutation has to be present in order to give resistance, because we do see cases that become resistant even with only 1% of the clone being mutated. Is that relevant as a mechanism of resistance or not? It's only bystander phenomenon. So these are all questions that are still there on the table, and therefore there is really no indication of using mutation at the moment in the clinical practice.
Thank you, Paolo.
Thank you so much.
Thank you.
I think it's about time. Thank you, Professor Paolo, for excellence and comprehensive talk. And we hope we can have a chance to, meet you in person and attend your talk in person next time. Thank you so much.
Thank you very much.
Thank you. So then we're going to move on to the next sessions. It's Asia Pacific CLL Consensus Guidelines and Discussions, which will be presented by Professor Eric Say. He's a professor of medicine, Division of Hematology Oncology and Stem Cell Transplant, University of Hong Kong Queen's Mary Hospital. And for this period, may I introduce the panel members for CLL on the stage with me. The first one, Professor B. Ping Chong from Department of Medicine, University of Malaya Medical Center. Please join me on the stage. Professor Borchenko. He's the Director of Department of Hematology Oncology, National Taiwan University Cancer Centers. And Professor Lee Jiang-yong, the Directors of Department of Hematology, First Affiliated Hospital of Nanking Medical University. Please join me on the stage. And now, it's the time for the CLL consensus, Asia Pacific CLL consensus. Please welcome Professor Eric Says.
So thank you, Loretta, for the kind introduction. And I'd also like to take this opportunity to thank the organizer for inviting me to give this talk. So Asia Pacific CLL Consensus Guidelines and Discussion. So here are my disclosures. So before we start on the Asia Pacific guidelines, we have to understand that CLL is often quoted as the most common leukemias in the West. But however, we do actually see a difference in the epidemiology in the Asian populations. The incidence, in fact, is much lower in Asians as compared with that in Caucasians. So these are the data extracted from the shared data in the United States, and and also compare with one of our own data published, unpublished, but some data for the Hong Kong Chinese, showing that we have actually a much lower incidence compared to the West. And this may be a combination of both genetic as well as environmental factors, or those data are still conflicting, because some may suggest that the CLL, the incidence actually persists, the low incidence persists in Asian immigrants to Western countries and remain stable over time, whereas other publications may suggest an increase in CLL incidence among Asian population migrate to the United States. And another kind of difference is that in the West, the most commonly quoted median age at presentation of CLL is 71, whereas in one of our studies published together with the Singapore colleagues, is that we have a kind of a lower incidence, a lower median age of presentation at the age of 64. Now, this is just again to show you the difference of CLL between Asian countries and the West. This is the distribution of lymphoid or mature lymphoid neoplasms in Asian countries compared to the West. So we can see that compared to United States, CLL in China, Japan, Korea are much lower, comprising a much lower percentage of all lymphoid neoplasms. So you can see that it's no longer the most common lymphoid neoplasm in the Asian countries. So for the management of CLL, we have different guidelines. Perhaps you have heard from Professor Gear that we have a lot of guidelines in the West informing physicians how to manage patients with CLL. So we have the IWCLL guidelines, we have the ASMO guidelines, and also, of course, we have the regularly updated NCCN guidelines for physicians in the United States. But we do not actually have a consensus until now that 15 of us among different places in Asia grouped together and draft this expert consensus on the management of CLL in Asia, which was published sometime this year. So it was published in the Clinical and Experimental Medicine Journal this year. So who are we? So we are sort of hematologists with an interest in CLL among different places in Asia. So we have hematologists from Thailand, from Vietnam, from Indonesia, from Malaysia, from Hong Kong, from the Philippines, from Singapore, and also from Indonesia. So how do we come up with this consensus? We actually based on sort of literature reviewed and discussions through meetings and qualitative survey. And the final decisions regarding the care of CLL patients will, of course, be made by the treating physicians after considering patient-specific factors, but not solely on this consensus. And this consensus is drafted through this modified Delphi methodology. So this is just copy from the paper. So if you're interested, you can go back to the paper and read. So we have different sort of consensus statements. So we have discussions and meetings, virtual meetings, going back and forth, and to achieve kind of a consensus. And for statements with nearest consensus, with no consensus, and we were discussing after each round for further refinement or omit completely. So we have a final certain something like 32 sort of consensus statement with different mean CCCS score, different agreement. So this is just to flip through. We have a lot of these consensus statement, 32 of them. So in the interest of time, I just go through some of the more important recommendations that we presented in this paper. So the first three is more on the diagnosis and evaluation of patients with CLL. So we believe that the presence of circulating monoclonal B lymphocytes more than 5 times 10 to the power 9 per liter, with the characteristic immunophenotype in peripheral blood for more than 3 months is sufficient to diagnose CLL. So we do not think that a bone marrow biopsy are essential for routine CLL diagnosis and should only be conducted if patient exhibits cytopenia, thrombocytopenia, anemia, and when the lymph node biopsies turn out to be small lymphocytic lymphoma without circulating lymphocytosis, then we should consider to do a bone marrow biopsy. But otherwise, we should not do a routine biopsy. And for imaging, such as ultrasound, CT, MRI, PET-CT, again, we do not routinely recommend the use of these imaging modalities for the evaluation of patients with CLL. Only we do that when we want to identify index lymph nodes for biopsy when transformation is suspected. So this is again just to show you that for CLL diagnosis, we need to have the typical immunophenotype. So the B cell marker CD19, 20, 22, especially the CD20 expression will be weak in CLL. And also typically we have the CD23 expression. Of course, these are all CD5 positive B cell B lymphocytosis. And if you see, let's say, someone with a CD23 negativity, one should also suspect mantle cell lymphoma. Perhaps maybe we need further evaluation to exclude mantle cell lymphoma in this group of patients. So this is just our consensus is very much in line with the IWCLL super guidelines. So bone marrow biopsy is not routinely indicated, and so routine imaging modalities are not indicated for evaluation of CLL patients. So the other recommendations, again, is on the evaluation of patients after making the diagnosis of CLL is both the Wright and Binet clinical staging system are recommended for use in CLL. And we should also perform, as you heard from Professor Glier, that 17p deletion and TP53 gene mutations are very important poor prognostic markers for CLL and also dictate how we manage our patients subsequently. So we recommend that we should perform FISH for deletion 17p and also mutation analysis for TP53 gene mutations before initiating first-line treatment and each line of treatment for relapsed refractory CLL patients. Again, as we heard from Professor Glier, that IGHV mutation also have a prognostic value, so we should also assess the IGHV mutation status. As again, you heard, when someone is treated with continuous BTK inhibitors, the prognostic impact of IGHV may not be that apparent. So with novel treatment, the test may not be that essential if we decide to treat the patient with continuous BTK inhibitor. So this is just the Wright staging, Binet staging, and just to show you patients with deletion 17p have very poor prognosis, so we should do that. And again, showing you in general, patients with mutated IGH3 have a better survival outcomes compared to those with an unmutated IGH3. So also for treatment, we should also adhere to the IWCL guidelines for the indication of treatment. And for asymptomatic patients with early stage disease like Wright 0 or 1 or Binet stage A should be monitored without treatment unless there's evidence of disease development or development of symptoms. This is just to show you that even with the novel agent, with the first generation of BTK inhibitor, ibrutinib, if we use it in the treatment of asymptomatic early stage CLL, we do not actually see an improvement in terms of overall survival. So we do not actually treat patients, early stage patients, even with the novel agent. So what about if patients require treatment when they develop progressive disease? For first-line treatment for fit patients under the age of 65 with mutated IGHV and wild-type TP53 without 17p deletion, either chemoimmunotherapy, FCR, or other novel agents to be considered. And physicians need to inform young patients about the risk of secondary malignancies when they are offered the option of chemoimmunotherapy or novel agent as an equivalent alternative. This is, I think, Paolo may also sort of roughly address that for young patients with mutated IGHV treated with the most potent chemoimmunotherapy, FCR, have a very long-term sort of survival, as you can see in this publications. So I think I don't want to repeat that, that I think Paolo have addressed. So for those with unmutated IgH3, the use of novel agents is much better than the conventional chemoimmunotherapy. This is just overall. So for first-line treatment, patients with deletion 17p or TP53 mutation should be over BTKI as first-line treatment, as alluded to by Professor Geer, because there's demonstrated high response rate and potentially long-lasting remissions in high-risk patients. And fixed duration of venetoclax and together with obinutuzumab may also be considered in this clinical setting. But as mentioned by Professor Geer, we know that continuous treatment with BTK inhibitor seems to be better off in patients who have TP53 aberrations. And in patients with significant comorbidities, but without the TP53 aberrations and also unmutated IgH3, BTKI is a reasonable treatment option and could be used in preference to chemoimmunotherapy because of lower toxicity and better efficacy. However, as in Asia, we have many times resource constraint, and it might also be difficult to obtain approval for the use of these novel agents in the frontline setting. So chemoimmunotherapy can still be used as a frontline treatment option in this group of patients. And since we have very good data for both the BTK, continuous BTKI treatment, and also fixed duration venetoclax to support the use without patients without deletion 17p or TP53 mutations and also mutated IgH3. And of course, the advantage of the use of venetoclax in this setting is the fixed finite duration, 1 year duration, as mentioned by Professor Geer. Oh, I just want, again, just to quickly show you the patient, if you're treated, young fit patient treated with FCR, if you have a deletion 17p, the median overall survival is only around 30 months. So even with the most potent FCR, if you have in young fit patient with deletion 17p, the treatment outcome is not optimal. Whereas in contrast, if you treat it with continuous treatment with ibrutinib, you can see the sort of the 5-year overall survival is over 80% in this phase 2 study. So again, using acalabrutinib, if you have deletion 17p, again, is much better than chemoimmunotherapy, bendamustine and rituximab, as you can see here. And also, of course, Paolo showed you here with fixed duration venetoclax together with obinutuzumab, although it's better than chemoimmunotherapy, but you can still see the drop-off, right, after the completion of treatment if the patient has TP53 aberration. I don't want to go through that again. So what about for relapsed refractory CLL? So we believe that both continuous BTK inhibitors or venetoclax in combination with rituximab, as in the Murana trial, may be considered the preferred treatment of choice for patients with relapsed refractory CLL, but not to repeat chemoimmunotherapy, irrespective of the deletion 17p, TP53 mutation status, and also the IgH3 mutation status. Because we've actually been shown with these novel treatment, be it finite treatment with venetoclax plus rituximab, as in the Murano trial, or continuous treatment with ibrutinib, or continuous treatment with acalabrutinib, is consistently been shown that they are more efficacious and more effective in the relapsed refractory setting as compared with the conventional chemoimmunotherapy. So for relapsed refractory CLL, irrespective of risk factor, we should use the novel agents rather than repeating chemoimmunotherapy. So some sort of final kind of recommendations. acalabrutinib being a second generation BTK inhibitor may be better tolerated by patients, and also for those patients who are intolerant to ibrutinib and have relatively few contraindication to ibrutinib, we can choose acalabrutinib instead. As Paulo has mentioned in his talk, acalabrutinib has a much better safety profile than that of ibrutinib. So for those patients who have cardiovascular problem or high breathing risk, acalabrutinib is preferred over ibrutinib. And it's also shown in studies, mainly retrospective study, showing that for those who cannot tolerate ibrutinib and was given acalabrutinib, these patients have actually very good response and also very respectable progression-free survival. And this is data showing you for those who cannot tolerate or been previously exposed to ibrutinib or even acalabrutinib, the use of zanubrutinib, another second generation BTK inhibitor, also can achieve very good overall response rate in this group of patients. So finally, measurable residual disease MRD evaluation. This assay is not available in all places in Asia. It's available in Singapore, Malaysia, Thailand, India, and Hong Kong, but it's not available in Vietnam and the Philippines. Now, we consider that MRD can be done at the end of the treatment after chemoimmunotherapy or venetoclax together with anti-CD20 antibody combination to predict the risk of relapse and overall prognosis, as mentioned by Paulo. Now, this is just to show you with chemoimmunotherapy, we can consistently see those who can achieve undetectable MRD has much better PFS as well as overall survival as compared to those who cannot achieve undetectable MRD after either FCR or bendamustine rituximab combination. And for FCR, there is also a small-scale phase 2 study showing that if one, after 4 cycles of FCR, if one can achieve undetectable MRD, is actually as good as those who actually have a total of 6 cycles. So for those who have 4 cycle undetectable MRD, one may actually consider dropping the last 2 cycles of FCR and probably will have the same outcome. So this is CLL14 data. Again, just to mention that patients who have undetectable MRD actually had a much better outcome. So I think that's all, and we can sort of go back and have a more discussion among the panel and the floor. Thank you.
Thank you so much, Professor Say. Would you please come back on the station now? I think we can discuss with the panel and also the floor. If anyone would like to raise the questions, you can. I'll go to the microphone. And yeah, so would you like to?
I just want to have a show of hands. How many of you have, in the Asian area, how many of you have approved of reimbursement for the use of these novel agents in the frontline setting? Either continuous BTK inhibitors or venetoclax plus obinutuzumab. Taiwan, Singapore, Australia, India, and China as well. Unfortunately, in Hong Kong, we still do not have reimbursement for the frontline use of these novel agents, even if the patient has deletion 17p or TP53 mutated. So these are the constraint. But we do have reimbursement for the use of these novel agents in the relapsed refractory setting. So again, I just want to have a show of hand. Let's say if someone has newly diagnosed CLL who require treatment, if you do not know, let's say, the TP53 mutation status, or you do not know whether this is IGHV mutated or unmutated, who would sort of use a fixed duration, or who would use a continuous BTK inhibition, or you will definitely want to know all these risk stratification and also the patient sort of individual patient characteristics before you decide on the treatment. So let's say who would wait until you have all the prognostic factors before you decide on the use of fixed duration or BTK inhibitors, who would wait until, I suppose most, if not all, will sort of want to have more data before you decide on the treatment. Now, again, I want to have a show of hand. Now, for you mentioned, I think Professor Gay has mentioned in his talk that for those with deletion 17p and also TP53 mutation, one should more inclined to use continuous BTK inhibitor rather than venetoclax obinutuzumab. Anyone would think otherwise. That okay, yes, we have one sort of a different opinion.
You don't have any direct comparative trials between ven-obin and continuous BTK. So you're comparing cross-trial data and you're saying that this has better response rates and therefore you want to use it, which is fine. But what is the difference in overall survival between these two groups? Do you have data to say that if a person with ven plus obin fixed duration TP53 mutated is treated and say he relapses after like say 51 months, which is the thing, and then you give him BTK continuous inhibition, what is the difference in overall survival between this group of patient and the group of patient who is given continuous BTK inhibition? Because cost is always a factor. If you treat for a fixed duration, and it's not that all the 100% of them are progressing at 51 months, only median progression-free survival. So you still have a proportion of patients who have done well with ven plus obin, even in the TP53 region. So this has to be discussed with the patient, and then one has to come to a discussion. It's not so, and especially you're only dealing with PFS. You're not dealing with a definite OS benefit. Unless you can show that the quality of life of patients who are using continuous BTK inhibition is better than the quality of life who are doing a fixed duration ven plus obin. The consensus, yes, you can always go by PFS, but we can't eat PFS now. You have OS, unless you show a clear OS difference between continuous BTK versus ven plus obin frontline setting, unless you have a comparative trial between them and you can show a very clear OS difference, the data is not really 100% clear.
So I agree with your argument, and we do not actually have a head-to-head comparison between fixed duration and also continuous BTK, unless we have the results of the CLL17 study, perhaps hopefully sometime next year. So any other things that the panel would like to discuss or address? Yes, Dr. Go?
I'd like to know from the guideline, I think you have a comprehensive description about the treatment of CLL, but may I know if there any suggestion for the patients with CLL and high-risk transformation? How are you trying to treat this kind of patient?
I think in that particular consensus paper, we think that for those with high-risk features, like for those with in particular, for those with TP53 aberration, we would suggest continuous BTK inhibition. And of course, as also sort of stated in the consensus paper, that fixed duration venetoclax plus obinutuzumab is still an alternative, as sort of also very well sort of alluded by one of our sort of delegates here. So we do believe that both are sort of good options, but in the present data, with the present data, we believe that long-term continuous BTK inhibition for these high-risk groups may be slightly better than the fixed duration. But we believe that the fixed duration is an alternative as well.
I do think for this kind of high-grade transformation, do you recommend any frontline autologous transplantation or even frontline CAR-T therapy for this kind of patient?
We haven't actually addressed in in our discussion when we formulate this consensus paper about Richter transformation, for instance, how we actually manage it. As we all know, Richter transformation is a very difficult to treat patients. So I'm just wondering when anyone have actually a consensus of a guideline in your local jurisdiction how to manage patient with Richter transformation. Patient with Richter transformation, any sort of
Maybe not guideline, but maybe personal opinion is also okay because I think it's quite a rare condition.
anyone who have sort of good recommendation how to treat patients with Richter transformation.
Society of Hematology meetings, and I think Prof. Othman mentioned that he would use something like a combination of a PD-1 inhibitor and then take the patient to an allogenic stem cell transplant. But I personally have not had an experience using that kind of an approach.
Yeah, I think there were actually preliminary data suggesting the use of immune checkpoint blockade in patients. But I think long-term data and now the current data this suggests that the use of immune checkpoint blockade is actually not that effective in patients with Richter transformation. And now many studies have now trying to combine venetoclax together with conventional chemotherapy for the treatment of patients with Richter transformation instead. Yes, Professor Kwong?
Well, in the first session, we heard about the impact of MRD on ALL. So my question to the panel here is, how do you evaluate MRD's role in the management of CLL patients? Now, obviously, we're discussing fixed duration treatment versus continuous treatment. So one of the roles of MRD may be in patients who are originally scheduled to receive continuous treatment. If they achieve an MRD negative status, maybe you can shorten the treatment, or in patients who have initially been assigned a fixed duration treatment, if the person still is MRD positive after a certain period of time, maybe you should continue the treatment onwards. So I'd like to hear your opinion on how you evaluate MRD and its role in the overall determination of whether you want to use a fixed duration treatment or a continuous treatment.
This is the thing that I would like to ask as well. For my for my opinion, I think MRD should be more followed for the patients if we plan, for example, patients on BTKs, and if we test MRD negative, persistently negative for over years, we would, I mean, the patients and the doctor should discuss about the chance of stopping. But this is not, I don't normally would recommend for the high risk patients. I would recommend for patients with standard risk patients that would stop if they have persistent MRD negative during the BTK treatment. This is what I think that I would offer.
We unfortunately we don't do MRD for CLL patient, so mainly based on clinical symptoms and the blood counts. Yeah.
In Taiwan, actually, novel agent, although it's reimbursed, but only partially reimbursed with quite interesting guidelines in the reimbursement criteria. We can use venetoclax and acalabrutinib and ibrutinib, all in second line, in front line only with TP53 mutation. And the duration is limited to 24 months. And you cannot change. Because once you fail venetoclax, you cannot change to BTKI. And once you fail BTKI, you cannot change to venetoclax. So in such a situation, actually, I must say that although MRD is available in Taiwan, but we infrequently check it because it doesn't make any possibility to have alternative treatment. So in practice, I think I will check if the patient receive a clinical complete remission. I personally will ask the patient to check the MRD maybe every 6 months, either with bone marrow or peripheral blood. But I will not persuade it because it doesn't make a lot of change in the reimbursement criteria. But if the patient can afford the self-payment, I think I will do this kind of monitoring.
Okay. So for MRD in CLL, do you use flow or use NGS?
Currently, we use flow. NGS is under developing.
Okay, thank you. Dr. Lee?
In our hospital, for the patients, young and fit patients with good prognosis, we have 2 clinical trials, including IFCR and OFCG, allelobrutinib. And after 3 courses, we detect the MRD. First in peripheral blood, if negative, and confirmed by next generation, then we can omit the FCR or FCG and continue for add rituximab or allelobrutinib. Another CD20 antibody new, and then for if MRD negative, we use the BTK inhibitor for one year and stopped it, and already complete the 2 trials. And MRD can achieve about 80% both peripheral and bone marrow, and the complete remission near 70%. Also by 8-color flow cytometry and next generation sequencing.
For your ibrutinib in combination with APLC, do you observe a lot of toxicity, increased toxicity?
So in the first three cycles, we can intensify supportive care, including ibrutinib and GCSF and SMG and antivirus. It's okay. No death. No death.
Excellent to hear, because we know that with ibrutinib, even in the Phoenix trial, combining with R-CHOP, actually we do see a lot of toxicity in patients receiving ibrutinib together with conventional chemotherapy. Now, I think for the MRD, as mentioned in the consensus paper, we only recommend tracking MRD or consider, or actually not recommend, consider doing MRD only if we treat the patient with a fixed duration treatment, either with chemoimmunotherapy and also venetoclax-based therapy, because we know that with continuous BTK inhibition, we do not actually see a lot of CR, let alone MRD negativity. So we do not actually suggest physicians to check the MRD if the patient is on BTK inhibition. Whereas whether one should check, I think is still debatable, and also we do not have a very strong recommendation on that, because we do not know how to deal with those patients. Even after fixed duration of treatment, if they are still not turned undetectable MRD, what to do with this patient? What's the best way to deal with this patient? So is more or less for prognostication purpose rather than guiding treatment. So perhaps we have to wait for more data, let's say from the Captivate, the MRD adapted cohort. When we have more data on that, we may be able to know how to deal with these patients who still remained MRD detectable after the fixed finite treatment with venetoclax-based therapy.
Do we have any data on what's the natural history of patients with TP53 mutation who are given fixed duration Ubin plus venetoclax and have become MRD negative?
Personally, I do not know if anyone actually particular because in the first place, these patients, we do not have a huge population of these patients because in the frontline setting, if you refer to TP3 aberration, including gene mutation and also deletion 17p, we have only around 8% of patients, all patients, with that in the frontline setting. So
in the trial,
in,
the Ubin venetoclax trial,
yeah, even with that, we do not actually have a lot of patients. If you're talking about even if the arm contains, let's say, 100 patients, only 8 patients are like this with TP53 mutated patients. So we may not have a big cohort of such patients to have that sort of data to tell us. So I don't know whether others are aware of that sort of data. Anyone? Dr. Lee or Dr. Go? No, unfortunately, we don't. Paolo, are you still with us? No, I think he's gone. Oh dear. So I think
Yeah, I think we have a lot of questions and discussions, so I think we can do that during lunchtime afterwards. So it's about time, and thank you, Dr. Says and all the panels that join us today, and also all the audience and everyone who joins these sessions. Thank you so much. Thank you. And we will come back again after lunchtime, and we will be at 1 p.m. for the AML sessions.